Welcome to the show, everybody. I'm your host, Jennifer Boozer, owner and founder of CannaBama in downtown Mobile. We are located at 558 St. Francis Street, right there in downtown, and we're open 7 days a week. So definitely come and see us. Our phone number is 251-255-5155. Our website is CannaBama.com, and you can find us on Sweet Home CannaBama pages on Facebook, Instagram. We are now official on X. So they are cannabis friendly, we hear. So we're kind of scooting over there since Facebook doesn't appreciate us very much. A little bit of current event news. I know last week I talked about how California and other states were starting to join this executive order club. And the only news that we have since then is out of Missouri. Thanks again to John Grady, to Brooklyn Hill, and the Missouri Hemp Trade Association for keeping us informed. Over 50 businesses have been hit, and this is of last week. Over 50 businesses were hit, and even though they were not mock Skittles and Lifesavers and things like their governor is accusing us of selling, their products were being embargoed and even destroyed. They were pouring bleach on these people's product. They had removed it from the shelves to be compliant with the order while they go through the legal issues. And they boxed it up, put it in the back room. You know, we had a product one time that got recalled, and it was a newer product, and it got recalled. We pulled it off the shelf. They said, stick it in a box with the name on it, and we'll send you a label eventually to get it back, and you'll get your money back. And instead of allowing them that, they were pouring bleach on their products and destroying thousands and thousands of dollars worth of products in all of these businesses all over the state. And the worst offense by the state, the DHSS, I believe is what it's called in Missouri, is on 9/11, they hit a VFW and they harassed these no children allowed establishment for veterans on 9/11. Possibly people were in there that day or patronized this VFW and supported that were, you know, in war during that time, that went to help rescue or went off to the Middle East after that, you know, and they went in and they harassed them and treated them less than. And it was, you know, they even said if it had happened on the 10th or the 12th, it wouldn't have hurt so much. But it was wildly inappropriate and offensive, especially to the veteran communities in Missouri who are part of the hemp industry. And there are a ton of awesome veterans that are in the hemp and cannabis space. So I do know that the Missouri Hemp Trade Association has now filed for a TRO that will be heard in court tomorrow. And like I said, we don't have any other updates from California or Tennessee. Nothing new has happened with Boro Hemp here in Alabama. And so we're going to move on to tonight's topic. I'm really excited tonight. We have a very special guest, and his name is Dr. Brent Boyett. He is an addiction medicine specialist from Hamilton, Alabama. Dr. Boyett works at the Neuroscience Institute at North Mississippi Medical Center in Tupelo, Mississippi. Dr. Boyett, welcome to the show.
Thank you so much. It's good to be with you, Jennifer. Appreciate the opportunity.
Absolutely. I want to read this disclaimer, and then we'll get into your bio. But for the listeners, we've posted this on the live stream as well. The information provided on this radio program is for general information and educational purposes only. While our guest is a qualified physician, the content discussed on this show should not be construed as personalized medical advice, diagnosis, or treatment. Always seek the advice of your own physician or another qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you heard on this show. The views and opinions expressed by the guest are their own and do not necessarily reflect the views of the radio station or its affiliates. So we got that out of the way. Everybody knows. We tell people that in the store. If you're on medication or you're coming to speak to some condition specifically, always want to talk to your doctor about adding a cannabis product of any kind, whether it's CBD, THC. I'll always talk to your doctor. We have a bright yellow sign at the register. Do not take this as medical advice. Go and talk to your doctor. So we want to make that clear. Dr. Boyett wanted to make sure that was clear. So let's talk about your bio, Dr. Boyett. So Dr. Brent Boyett is, let's all these letters. We were giggling about what some of these letters meant. DMD, DO, and this one's my favorite. I need you to explain it. DFASAM.
That
It's a
means,
distinguished.
yes,
Go
there you
ahead.
go. Yeah, distinguished fellow through the American Society of Addiction Medicine.
Nice. Oh, right. So Dr. Boyett is a distinguished professional with a unique background in both dentistry and medicine. He first earned his doctorate in dental medicine and practiced dentistry on the weekends while pursuing his doctor of osteopathic medicine. And this dual expertise allowed him to establish a multidisciplinary practice in Hamilton, Alabama, where he seamlessly integrated both fields. In 2018, Dr. Boyett became board certified in addiction medicine. Recognizing the growing need for specialized care in this area, he decided to stop practicing dentistry and dedicate his career to addressing behavioral and emotional disorders. His approach focuses on the biopsychosocial model. That one tripped me up. And contingency management, ensuring comprehensive and effective treatments for his patients. Dr. Boyett's commitment to behavioral and emotional disorders and his innovative treatment methods have made him a respected figure in the medical community. His work continues to make a significant impact on the lives of those struggling with these disorders, people like me. Again, welcome to the show, Dr. Boyett.
Thank you so much. I appreciate it. Great to be here.
Well, let's get on into it. How did you become interested in addiction medicine? You were doing dentistry and dental surgery, right? We spoke about that, and then osteopathic medicine. What kind of made you decide that addiction needed to be faced?
Well, Jennifer, I'm an Alabama native. I grew up in Northwest Alabama, a little small town called Sulligent, Alabama. And
Oh,
I
wow.
went and became and got my dental degree through the University of Alabama at Birmingham and was really attracted to the medicine side of dentistry. I enjoyed the anesthesiology. I enjoyed um, um, just the broader approach. So I finished dental school in 1994 and then went straight into osteopathic medical school. Did 4 years of
Hmm.
osteopathic medical school, finished that in 1998, and did a family medicine residency through the University of Mississippi. And I finished that in 2001. And my plan was to come back to Northwest Alabama, the area where I was raised, and to basically serve the people there. And I
Right,
had been gone for about 12 years. And so when I returned after my education, this was not the home that I had left. This
right,
was right around the turn of the century, 2000, 2001. And what I came back to was a community that was devastated by primarily the misuse of prescription medications, namely opioids and benzodiazepines and other controlled substances. And so
right.
what I found was that it not only affected the health of our people, but it also affected the psychology, the reality, and ultimately the entire social fabric of our community. And
Right.
it changed.
Families, jobs, being able to stay out of jail, maintain your debt, all those things. Every aspect of life is affected by that.
Absolutely. And I saw it in the community. So when I was practicing in the dental office, I saw it. When I was practicing in the family medicine office, I saw it. I did some emergency medicine work. I saw it in the ER. So I began to try to figure this thing out and begin to study behavior. And really
Hmm.
was fascinated by the science of actually cognitive behavioral approach to pain and pleasure. And that's really what it
Right.
boils down to. And so
Dopamine. Yes.
dopamine, yeah, exactly. So I always just explain that this addiction medicine is the field of medicine that helps patients establish and maintain a functional balance in their perception of pain and pleasure.
Right.
And when we can do that, then the drug use takes care of itself. And so that's one of the keys is that we have to pay attention to the fact of consciousness and what compels a person to
Right.
engage in a dysfunctional behavior like drug abuse.
Right. And when you said when you returned home, you live up near Walker County, which anybody who knows anything about the opioid crisis in Alabama knows that Walker County is probably the worst county as far as the amount of drugs, prescription drugs specifically, that come in and out of that area of Alabama.
That's exactly right. Walker County, Marion County, Franklin County. As a matter of fact, Harvard issued a report that looked at opioid prescribing per congressional district in the United States. And they found that the
Hmm.
number one congressional districts in the entire country in the entire United States for per capita opioid prescribing was Alabama Congressional District 4, which was Robert Aderholt's
Wow.
district. And so that's
Wow. When we come back from the break, we're going to talk with Dr. Boyett some more about addiction and cannabis. Stay. Welcome back, everybody. I want to give a special shout out to my friend Sonia in Tuscaloosa, whose awesome commercial we just heard. That's my favorite commercial I've ever gotten to record. But Facebook deleted her business page just like mine, but they then deleted her personal page, and she's been on Facebook since like '08. And so she's having to recover from that. So y'all make sure you look up Freedom Wellness is her new page, Freedom Wellness on Facebook. I'm sure it's with Instagram as well. Anyway, they just don't like us. I told y'all. So tonight we're talking with Dr. Brent Boyett, who is an addiction medicine specialist from Hamilton, Alabama, and he works at the Neuroscience Institute at North Mississippi Medical Center in Tupelo. Doc, how did you become so interested in chronic pain once you saw that everybody around, all the community around you was being destroyed by these opiate prescriptions and benzo prescriptions? What made you decide to focus on chronic pain?
Well, chronic pain drives a lot of addiction. In fact, I always just say that at the root of addiction, there's always pain. And so, whether that be physical, emotional, but usually a combination of both. And so,
Right.
physical and emotional pain affect each other bidirectionally. One exacerbates the other.
Absolutely.
Yeah.
Absolutely.
And so it's in order to just focus on the behavior and not to focus on the underlying compelling conscious problem that drives the behavior is kind of short-sighted. And so that's kind of
Right.
the whole point is to change the consciousness, and that can change the behavior. And so, going to the root of that pain, whether that be emotional pain, physical pain, or a combination of both, is essential for recovery and maintenance of recovery.
Right. I posted something the other day that said trauma is actually the gateway drug, because for me, I had a physical pain issue, injury, but I also had lost my son and
Right.
wasn't handling it well. And those two things created a perfect storm, because when you are emotionally distressed and traumatized, it exacerbates your ability to feel the pain, and it definitely tamps down your body's natural ability to combat that and give you what you need to cope with it. And when you, for me, my first experience with that was I had a bulging disc in my neck, and I was deeply grieving 6 months after my son died. And when I took the pain pill, the noise in my head stopped, and the deep ache in my chest stopped, and the world got quiet, and I could interact with my husband like a wife should, and I could interact with my son like a mom should. And wow, this was great. And I would do that occasionally when it got too much, and then it got to be every day, and then it's this roller coaster. But it definitely was rooted in emotional pain that exacerbated over long term my chronic pain, because I was a chronic pain patient since the age of 15. But definitely that was the perfect storm, the emotional turmoil and the crushing of my spirit over that, while I was also enduring the physical, explosion of my insides and surgeries and all those things, and learning to live again. I mean, one begets the other and vice versa.
That's exactly right. As a matter of fact, adverse childhood events, and there's actually a score to grade adverse childhood events, which can include abuse, neglect, and other types of things. But that is just as good, if not a better predictor of back pain as pathology on an MRI, particularly degenerative
Wow.
disc disease, which is not necessarily that good of a predictor of back pain.
I have that. Wow. Oh, wow. Okay, so let's keep going. How did you become interested in cannabis as medicine?
So I will tell you this. I came into cannabis kind of accidentally. I have built my career and focused my career in addiction and the
Hmm.
pains that lead to these self-destructive behaviors. But I had the opportunity to go and take over a program that was previously managed by anesthesiology, and it was the medical pain management program at North Mississippi Medical Center. And I knew that legal cannabis was coming to Mississippi, and so
Yes.
I felt I felt compelled to become educated in cannabis as much as I could, and to introduce cannabis as a treatment option in the North Mississippi Health Center as scientifically and as responsibly and ethically as possible. And that's what we sought to do. And so I've been studying cannabis for the last 3 to 4 years, and I have been actually working with medical cannabis for the last 2 years in my clinical practice. And I will tell you this: I was a skeptic of cannabis. I would be the
I
first
was
to admit.
too.
Yep.
I was too. I turned it down.
Yeah.
I was
I
too.
was. Yeah. I have seen cannabis use disorder, and particularly in adolescents and young individuals. So there is a
Hmm.
concern in cannabis and cannabis misuse. However,
Right.
there are arguably more concern with the medications that we have become, in my opinion, far too comfortable prescribing, which are benzodiazepines and opioids and these kinds of things. So, I mean,
Absolutely.
while
Well, my son at 16 was prescribed opioids because he broke his ankle and his leg and tore all the ligaments, had to have surgery. And I was terrified, because here I was, what, 2 years clean,
right,
that bondage. And I know my dad died of an accidental overdose of pills, and I'm like, I can't allow this to happen to my son. And it was terrifying that they so casually, I mean, he had a major surgery, but I
mhm,
remember being 15 and having migraines, and they would give me Lortabs, and I got in trouble at school one day for scratching my nose too much because I was high
mhm,
as a kite. I
mhm,
was 15, and I know that oxycodone was approved for use as young as 11.
right. Yeah.
So
The
it's
truth of the
crazy.
matter is, yeah, the truth of the matter is, with regards to pain management, and particularly chronic pain management, we just did not have that many tools in the toolkit. I mean, it's
Right.
opioids and just a few other
And
types
that's
of things.
it.
Yeah.
Right.
So
Sedating people and then becoming vegetables and addicts. That's
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 right.
all there is.
That's exactly right. And so we needed more tools, and cannabis just turns out to be a very effective tool. It's not for everyone,
Mhm.
but it certainly
Right.
has become a valuable tool in my toolkit in managing chronic pain.
Right. Right. Well, ok so what do you think the benefits of cannabis are compared to those other treatments? I mean, I know from my experience as a patient what I think, and then as an educator and doing this and being part of the industry, what I've learned. But I would love for the listener to hear, what do you think the benefits are compared to opioids?
Yeah, I think that there's several, a couple of things, and the clear and obvious ones are the lack of respiratory depression associated with cannabis.
Yes.
There's good evidence to suggest that humans have kind of co-evolved with the cannabis plant to the point that human beings have a relatively low CB1 receptor density in the brainstem, which is responsible for respiratory drive. So,
Right.
unlike opioids, which
Which is
intoxicate,
why an opioid would make you stop breathing, is that brainstem location. When you get too much, it depresses your breathing till you stop breathing.
that's correct. Yes, that's right.
That's how my
The,
father died. Yeah.
the brainstem, the rostral medulla and the parotid gray, which are parts of the brainstem, are chocked full of opioid receptors. So the
Hmm.
higher plasma concentration of an opioid, particularly a full agonist opioid, the greater the respiratory drive is depressed, and subsequently death occurs. And so that's one thing. But here's another thing.
Hmm.
As an addiction medicine specialist, I kind of live in the world of receptor dynamics. And so you've got to keep in mind that these neurons that we have in our brain all have receptors, G protein receptors on them. And we use these receptors to
Right.
basically we hijack these. With opium, we're hijacking beta endorphin receptors. With cannabis, we're hijacking anandamide and 2-AG receptors. They're CB1 and CB2 receptors. But I'll tell
Right.
you this, and this is anybody that understands molecular biology will agree with this, that when you stimulate a G protein receptor, if you can use a partial agonist ligand, which is much gentler on the receptor compared to a full agonist ligand, you will destroy much fewer receptors, and as a result, you wind up not having receptor damage and downregulation, and subsequently, interestingly enough, delta 9 THC is a partial agonist ligand at the CB1 receptor. And so therefore it's less damaging to this receptor compared to oxycodone, hydrocodone, heroin, fentanyl, morphine, which are
I
full
can't
agonist
hear.
ligands.
Yeah.
Sorry, Doc, I can't hear you.
Oh, I was just saying that delta 9 THC, can you hear me now?
It sounds like it.
Are you there?
We're not getting him on the air.
Doc, are you there?
Getting him on the
Yes, I'm here. Can you hear me?
Okay, we can't hear you on the radio.
Okay. What should I do?
I'm not sure. I'm not sure.
It sounds like his phone signal.
It sounds like your phone signal is breaking up on your phone.
Okay, let me try something different here.
That's okay. Our audience is. We're about to go to commercial break anyway.
Okay, is that any better?
Oh, yeah.
Yes. Okay. All right. We got you back. It's got a little bit of an echo, but we're about to go to commercial break in a minute, and we'll just fix that right up.
Okay.
All right.
From here,
How much time do we have before the break?
45 seconds.
Okay. Well, I do know, I will say, if you can hear me clearly, that I'm interested in, definitely agree with you on the lack of respiratory depression being a huge plus for the plant, because we know that benzos and opioids and even muscle relaxers like somas, I know that that's what they used to give me. Those will slow your respiratory activity until you basically stop breathing. That's how my father died, probably 14 years ago now, is an accidental overdose. He went to sleep and he never woke up. And I kept using for 5 years after that. And I'm not proud, nor am I saying that lightly, but that's the grip that these things have. And what he's saying about the massive opioid receptors in those parts of the brain, those I think are they say 2 years before the brain goes back to normal activity. When we come back from the break, we're going to talk more with Dr. Boyett. Stay with us. Welcome back to the show, everybody. Tonight we're talking with Dr. Brent Boyett, who is an addiction medicine specialist. He is also an active medical cannabis doctor in Mississippi. So if you're listening in the Mississippi Gulf Coast area, look him up. Look him up. Might be somebody worth visiting. I know that there are a lot of doctors in Mississippi, and kudos to Mississippi, because we here in Alabama like to think we're better than them. But they've had their hiccups. Don't get me wrong. That whole one typo, throw out the bill thing, that was low. And I know they've had their hiccups, but their program is really helping people. And Alabama, we're just suing each other. So for those of you in Alabama who are anxious to talk to someone or hear from someone who does this currently right next door in Mississippi, and some of y'all up near Tupelo might not mind the drive just to get some advice, but know where these experts are. We want to get you this information. Dr. Boyett, let's go back to the benefits of cannabis compared to other therapies. We talked about the lack of respiratory depression and then the receptor dynamics before your earbud went out. So let's continue to talk about that.
Sure. The receptor dynamics piece is really important too, because that is the core of addiction. And that basically means that anytime that we overstimulate a receptor group, in the case of opioids, we're overstimulating mu receptors and dopamine receptors, which are very dynamic receptors. We damage these things, build up of beta arrestins that build up on the receptor and block signal transmission, causes a deafness of the function of that receptor group. And so not only do we get a desensitization to exogenous opioids like oxycodone and hydrocodone, but we become resistant to our body's own endorphins, which are natural pain relieving mechanisms. Cannabis, on the other hand, is significantly less damaging to their receptors because Delta 9 THC is a partial agonist ligand. And that just basically means that it does stimulate the receptor, but it does it in a much gentler fashion than any full agonist ligand. Full agonist ligand in the CB1 receptor class would be something like spice. And that is harmful and causes damage.
Of course, but that's not naturally grown cannabis. That is some kind of biomaterial sprayed with chemicals. Am I right?
That is correct. Yeah, that's correct. And it's, cannabis, which is a phytocannabinoid, is a gentler approach. Now, let me say this, that higher doses of cannabis, and you can overcome the ceiling effect of the partial agonist activity just by crazy doses. So, in moderation is best. Having said that, it is certainly safer in a lot of ways than the medicines that we have been using, like benzodiazepines and opioids.
Which shouldn't even be used together, right?
That's right.
I remember when my father died, my pain management doctor across the bay gave me a low dose of Xanax or something because I was very upset. And when I went to fill both prescriptions, the pharmacist wouldn't fill it without speaking to my doctor, because he's like, yeah, you can die if you take these together. I'm like, oh, well, I was just a little sad.
That is true.
It's crazy. Of course, he went to prison. So
it's a combination of respiratory depressants, but it's even much more than that, because benzodiazepines cause a dopamine release through the GABA system, whereas opioids cause a dopamine release in the opioid system. But they both overstimulate those dopamine receptors, causing a dopamine receptor downregulation. And in a very real sense, addiction is dopamine resistance in the same way that type 2 diabetes is insulin resistance. It just takes more and more dopamine and more beta endorphin to achieve the same effects.
Right, which is why I went from taking a 7.5 milligram Lortab to 60 milligrams of Oxy at one time.
That's right.
Because my body got so accustomed to it, I needed more and more and more. And that's why I started running out of pills and going through withdrawal every month. And it was a horrible cycle. But even though at the end of the 2-week cycle of withdrawal, I would still go and get those daggum pills.
That's right.
Because I still felt so bad. And I needed that. And as many times as I said, I'm not going back, I went back every time until the last time. And then I knew I had to tell the doctor, do not give me this. I am abusing it. So he would legally know not to give it to me. I knew I had to cut myself off. That was the only way I was going to succeed. I was not going to wean myself. I was not going to do it. I
Right.
hadn't played by the rules so far. Wasn't going to start, you
Right.
know, and it was absolute hell on earth.
That's
You
right.
take that out of the brain after 10 years
Mhm.
and your brain's like, okay, well, we don't play this.
That's right.
And it just like your whole body hates you for a long, long time.
That's true. Jennifer, the condition you're describing is well known, and it's called opioid-induced hyperalgesia, OIH, and it's a well-known phenomenon. And what this really means is with chronic and long-term use, opioids can actually amplify and perpetuate the very symptoms they intend to treat. And this is
1,000% true.
absolutely. And so because of this reason, there's currently a $55 billion class action settlement being paid out by the pharmaceutical industry for the brain damage caused by prescription opioids.
Wow.
And so, I mean, that's being paid out. The state of Alabama is getting hundreds of millions of dollars in the settlements.
Well, maybe
As-
I ought to look into that because 3 of my doctors in Alabama went to prison.
yeah,
Both sides of the bay, too.
it
Whew,
is true.
Mobile and Baldwin County.
It is true. And that's the situation. Over time, a person gets caught up in a cause and effect loop that essentially says, do I take opioids because I'm in excruciating pain? Or am I in
Mhm.
excruciating pain because I take
Because I
opioids?
take opioids. Yep, one
Yeah.
begets the other, and I told you this earlier that for me, I white knuckled it, and then God delivered me from that craving at about 3-week mark, but my body still had to get back to normal. I had to learn how to pick myself up off the floor and literally survive 30 minutes at Walmart, and it, and 2 months, 3 months maybe, I had less pain after 3 months without the opioid as I did taking 60 milligrams, every 3 hours.
Right.
So that told me this was because I had read that, but I didn't believe it. But sure enough, I was like, man, I got to admit, this is true. I have less pain now than I did when I was eating that like candy. And I told myself I needed it. So there's definitely light at the end of the tunnel. I mean, I'm 10 years clean next month. But cannabis has been a big part of that.
Right.
And that's why we wanted to have you on. What about, besides the receptor dynamics, was there any other points you wanted to make about the benefits compared to other therapies?
Well, I do think that there are other benefits that cannabis offers besides just analgesia or dopaminergic reward.
Well, yeah, you
And
could
that is
replace your anxiety. I did. I replaced anxiety medicine,
right.
antidepressants, and sleep medicine,
That's right.
which
So
that's what we hear the most is anxiety, pain, sleep, or a combination of those things.
I think what makes physicians so uncomfortable with the concept of cannabis is a couple of things. First of all, we were taught almost nothing about this in medical school. The endocannabinoid system, the receptors were only discovered in the 1990s, and their activating ligands were discovered in the late 1990s. And most of that research was done in Israel and not in the United
Right,
States because cannabis has been locked behind a vault of prohibition for the last 60 years.
right.
And so
Yes, we know all about Dr. Raphael Mechoulam and his research.
absolutely. So, credible science has been difficult to get in the United States. And
Right.
secondly, cannabis, most medications that physicians are comfortable with and familiar with are monomolecular. It's one molecule that's doing one particular thing, sometimes a combination of two molecules, but it's
Right.
usually pretty simple pharmacology. In
Hmm.
cannabis is multimolecular. In other
The
words, cannabis
entourage effect.
entourage effect is exactly right. So we're talking
Yes.
about dozens, if not hundreds, of medicines of different drugs that have different molecules that can have clinical effects. And so
Right.
even some molecules in the cannabis plant can enhance or inhibit other molecules. So it's very complicated. The analogy that I use to describe this to patients is I say that most medicines are monomolecular in that they are like a violinist standing on a stage playing a violin.
Hmm.
Whereas cannabis is like an entire orchestra playing together. And so,
Yes.
in order to understand how to manage medical cannabis, you have to understand each individual musician playing in the orchestra. That's the reason
And
why.
and each instrument.
That's
There's
exactly right.
so much, over 400 compounds in the plant. And you're right. We talk about terpenes and flavonoids, and those are, I think I've read around 100 different terpenes in different proportions. Flavonoids, 148, I believe, cannabinoids that we know of, and that's a ton of different ratios, and that's what makes up the different strains, is the percentages of the different terpene profiles and stuff. And I love the plant because it's as unique as we are. No, there's no two of us the same.
Mhm.
And that's what I think makes cannabis such a great medicine.
When managing cannabis, I believe it's really important to pay attention to the content analysis of each product that you purchase because, as you've mentioned, even though you can have genetically identical plants through cloning processes and other types of
Hmm.
technologies, even the growing conditions may
Right.
cause a
One
difference.
corner,
Yeah,
yeah, one corner gets more sun or more rain, or,
that's right.
something can happen, and each plant can be different.
That's right. Just like humans, where we are a product of both nature and nurture, cannabis plants are products of both nature and nurture. And so the content analysis can be very much affected by all of these factors. And,
Right.
and so, for instance, not all cannabis is the same. And so if you are trying to treat, let's just say, um, uh, seizure disorder, you
Hmm.
might want to use a chemovar that is higher in CBDV, which is shown to have anti-epileptic properties and raises seizure threshold. If you were trying to treat nausea, you might want to have a chemovar that is higher in THCA,
Right.
tetrahydrocannabinolic acid, which has
Hmm.
30 times the antiemetic effects of just delta 9 THC.
Really?
Um,
I did not know that. That's
it does.
amazing. I knew it was good for nausea, but not that good.
Yeah,
That's amazing.
it's much better. CBG can have antimicrobial effects and
Right.
anti-inflammatory effects. Beta myrcene, a common terpene that is found in cannabis, can have muscle relaxation effects. Can be quite beneficial in muscle spasms. However, it may also cause couch lock, which is an unwanted side effect in some cases. So it really
Hold
defeats.
that thought. Hold that thought. Dot. We got to go to a break. We'll be
Okay.
right back with Dr. Boyett. Stay with us. Welcome back, everybody. We're here every Monday night at 7 o'clock right here on FM Talk 1065 and live streaming from the Sweet Home CannaBama pages on Facebook, Instagram, and now on X. Bunch of other pages. Thank you to the groups and the people that allow us to stream from their pages within the hemp and cannabis industry and the advocacy community. There's a bunch of them. And so tonight we're talking with Dr. Brent Boyett from Tupelo, Mississippi's Neuroscience Institute at North Mississippi Medical Center, an addiction medicine specialist from Hamilton, Alabama. Doc, let's get into, you wrote a white paper about medical cannabis. And one of the things that struck me as interesting that I have actually seen in the store is something called operant conditioning. Explain what that means.
Operant conditioning is another name for Pavlovian conditioning, and you may remember this from high school psychology.
Pavlov's dog.
Pavlov's dog, exactly. So Pavlov
I think
famously,
that's freshman year of college, 101 psych.
that's exactly right. So Pavlov famously had tubes in dogs' necks. He was studying dog saliva, and he noticed that the dogs would begin to salivate when the lab technician who fed the dogs came into the room, and he recognized that as a response to a stimulus. And so he wound up ringing the bell, giving the dog a food treat, ringing the bell, give the dog a food treat. After a while, the dog becomes conditioned to the ringing of the bell. He associates that sound or that stimulus with the reward that's about to come, and subsequently,
and
he salivates. And so what we know about operant conditioning, and this is one of the pillars of addiction itself, is that you for instance, nicotine. You smoke a cigarette, you suck smoke into your lungs, you get a nicotinic receptor activation treat, and it's a good boy, good boy, good boy, and you learn to every time that you inhale smoke that you're going to immediately get a reward, and subsequently you fall in love with the behavior. You feel compelled to smoke cigarettes. And you say, why do you smoke those cigarettes? He says, I don't know. I just feel compelled to do it.
I've always wondered why, because I have been a smoker. And I always wondered, why do people always smoke right after meals?
Yeah.
Like it's like nobody tells you that's a rule, but immediately after a meal, you want to smoke. And it's like a universal rule. I've never met anybody that did not agree with that. And that's weird to me.
Well, I think it seals the deal on pleasure. In other words, no pleasure is complete until those nicotinic receptors are activated. So after a good meal, it's good, but it's not perfect until I can get outside in the parking lot and burn one. And so,
you know what the weird difference in cannabis and cigarettes is? That most people that I know that smoke cannabis have to smoke before they can eat.
Right.
Instead of after.
Yeah. Certain chemovars, certain cannabinoids are appetite stimulants. There are some that are appetite depressants. And so, that's like, for instance, THC V has been found to be an appetite suppressant and an energy booster. But with regards to the operant conditioning, the faster the reward following the dosing behavior, the more reinforcing the dosing behavior becomes. So for instance, the reason why smoking is so much more addictive than just say putting on a nicotine patch and wearing it is because of the rapid reward that occurs. So
that blood-brain barrier pass that's just almost instantaneous.
That's exactly right. So if Pavlov would ring the bell and wait an hour and a half to give the dog a treat, the dog would never fall in love with the ringing of the bell. He would never associate the ringing of the bell.
It would just be a sound that he heard every day at 2:00.
That's exactly right. And even in dog training, we take advantage of this. I'm kind of a hobby dog trainer myself. And so when a dog gives me the behavior that I want, I'll say sit. And as soon as the dog's butt hits the ground, I will mark that behavior with a clicker. Click, 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 click. And as soon as I can get to her, I'll give her a treat. But I'm marking that behavior. So that's the thing about inhaling smoke, or the rapid reward. You're marking that behavior and immediately you get a treat, whether that be nicotinic receptor activation or, in the case of cannabis, CB1 receptor activation. And
that's why people also will smoke pills.
That's right.
Smoke other drugs. Yeah.
Exactly. Yeah. The faster the onset of reward, the more reinforcing the dosing behavior becomes. Crush and snort for opioids is faster than swallowing the pills. Of course, shooting them and is faster than that, and so forth. So when we brought cannabis to North Mississippi and we wanted to do it in a medical, ethical way, we decided that we would not certify for any inhaled routes of delivery for a couple of reasons. Number one, there's evidence to suggest that smoking in any form is harmful to your lungs and your back.
It is combustion.
Yeah. And secondly, even with the vapes, there have been problems with some of the lipophilic components like vitamin E that have caused lung damage and so forth. And then then thirdly, and this is an addictionologist, I think this is incredibly important. I want to delay the reward following the dosing behavior. In other words, I would like, it's actually a good thing that it takes swallowed cannabis at 30 minutes or 2 hours to kick in and work, because there is significantly less chance of compulsive misuse. When I tell my patients, I want you to use cannabis therapeutically, not compulsively. And a way to avoid compulsive use is to delay the onset of reward temporarily by time.
I see this a lot, and that's why I wanted to bring this up, because when I am trying to give people information about methods of consumption, how they work in the body, bioavailability, so that when they come in and buy something, they know how to correctly use it. I have the hardest time talking, talking to people who only smoke or vape. They don't want nothing else. Even if I'm explaining how a microdose several times of a day is not as good as a macro dose twice a day, and here's why, and all that, they don't care. They want that instant gratification, and they will, to their own detriment, skip over an oil or a capsule or an edible that will take more than 3 seconds to get to the brain, and affect them. But what they don't like, we have to say, when you inhale, you're microdosing, it hits you fast, but then it wears off fast. And for people like me with chronic pain, I would have to hit that sucker once an hour at least, and that's no way to live. Then again, the lung damage. Why not? We tell people, you start low and you go up until you find what works for you, and then you stop there, because more isn't more. More is just more money. And as addicts, everybody that's been an addict thinks more is more. And that's another battle. But the operant conditioning, I see that, because people who like that instant gratification, they cannot be talked out of it, to their own detriment.
Well, they've got a word for it. It's called the hit, the hit off of a Marlboro cigarette, or the hit off of crushing and snorting your oxycodone or injecting your oxycodone. It's a hit, and that's a treat, and that's a reinforcing behavior. And so we want to avoid the hit. We want the pain relief to be gentle and slow, and not hit you like a freight train.
Yes, I agree, because and that's a whole other conversation. We're about out of time. Thank you, Dr. Boyett, for your time and for sharing with the listeners tonight. Do you have anything you want to leave us with?
Just the fact that cannabis is a complicated, a multimolecular medication, and your physician should understand the entourage effect, understanding that CBD may block sedating effects, CBN may enhance effects. There's a lot to unpack about cannabis, and your physician needs to be educated in the way to conduct the orchestra. That's the key. Yeah.
Yes, I love that we both use a different version of the same analogy for the endocannabinoid system as a symphony or an orchestra, because that just made sense to me, and that's how I teach my customers. So I appreciated that. We thank you so much again for your information, and you can find out more about Dr. Boyett at the Neuroscience Institute at North Mississippi Medical Center website. And Dr. Boyett, are you on social media?
I am on social media. I am also on drbrentboyett.com, and I also have a couple of books on Amazon. One is called Healing or Harming by Brent Boyett, and the other is called Move Beyond Pain, and both of these are on Amazon.
All right. That's awesome. Thank you so much. Thank you to our listeners. Join us here every Monday night at 7 o'clock, and come see us at CannaBama. We're there 7 days a week, even on Sunday from noon to 5. And of course, 24 hours a day, we're on our website and on social media, so that you can find us. We're going to be celebrating National Recovery Month. I don't even think I mentioned that. But next week, we're going to hear from my good friend, Mr. Waxy Brown. Thanks for being with us tonight. God bless and good night.